Hello, everyone. It's my pleasure and my honor to welcome all of you tonight to one of our weekly online series. On behalf of the Educational Board of the Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome the speakers, moderators, and attendees to this creative and prestigious continuous opportunity to deliver not only an up-to-date curriculum in the field of anesthesiology, critical care medicine, and pain, but also to gather unique speakers and moderators from all over the globe. This opportunity is and will remain a great and successful experience in the current and the future virtual learning, especially during the current pandemic. Tonight, we have a special topic in anesthesia and pain with unique speakers in the field. I would like to welcome Dr. Hamad and Dr. Ahmed Lafir Aliar on the panelist side, and Dr. Nicolita Stoacia, Dr. Yasser Reda, and Professor Mohammed Makharida on the speaker side. Our first moderator is Dr. Ahmed Lafir. He is currently an associate consultant at Hamad Medical Corporation, Qatar. He is a fellow of the College of Anesthesiologists of Ireland, and he holds a certificate of the Arab Board of Anesthesia and Intensive Care, and also a fellowship in anesthesia from Hamad Medical Corporation. Dr. Lafir is an anesthesia program coordinator for the Qatar Board of Medical Specialization and the department co-lead of IT services. He's also an instructor in the Airway Management Academy, Qatar University, and Will Cornell Medical College for students. Our second moderator is Dr. Hamad Al-Futuh. She's currently a consultant in anesthesia and intensive care in Ministry of Health's United Arab Emirates, and a lecturer in Al-Munawwara University in Egypt. She has a master, MD, and a certificate of Arab Board of Anesthesia and Intensive Care. Dr. Abul Futuh has a special interest in obstetric and regional anesthesia. Dr. Ahmed Lafir, the microphone is yours. Please go ahead.
Thank you, Dr. Ahmed, for those wonderful words. Hello, and welcome everyone to this anesthesiology, mega online anesthesiology course. Before I move on and introduce my first speaker, I'd just like to bring it to everyone's attention that at the end of every presentation, we will have 5 to 10 minutes for discussion. And if you have any questions, please type it down in the Q&A tab that you'll find at the bottom of your screen. Now, so one of the moderators will bring up the questions as and when appropriate. So moving on to our first presenter, it gives me immense pleasure in introducing Dr. Yasser Reda Toble, because I've had the wonderful opportunity to train under him. He's known for the enthusiasm and energy that he brings to the program and the innovative and entertaining lectures and presentations that he gives. Dr. Yasser is currently working as a senior consultant of anesthesia at the Hamad Medical Corporation in Doha, Qatar. And he is also the lead for the interventional pain service and the post-anesthesia care unit. With at least 8 different certifications from around the globe, and he also is the course director for the Ultrasound-guided Regional Anesthesia and Pain Intervention Workshop. Today, Dr. Yasser Reda Toble will be presenting on the topic of opioid-free anesthesia. Please help me in welcoming him to the stage. Dr. Yasser Reda.
Thank you, Dr. Lafir, and thanks for the organizer, especially Dr. Saad Mahdi, and a special thanks for attendees. And thanks for giving me this precious chance to share with you some of this scientific knowledge. And a special thank to Dr. Yasser Zaghloul from Dubai, because he inspired me and gave me some of the material for these lectures. But I just will return back to the history of my history when I started my career in anesthesia, and to know the definition of anesthesia. It was analgesia, and this has come to my mind as opioid all the time: analgesia, opioid, and loss of consciousness and muscle relaxation. And all the time when I remember the analgesia, this means morphine. This is a father of narcotics all the time. And at that time, this is built in my mind that morphine is one of the pillars of anesthesia, or just opioid, one of the pillars of anesthesia. Later on, when I grew in the field of anesthesia, I understand that we can totally independent of narcotics, because narcotics or just opioid have what's called devastating side effect. And this happened when the American hate this opioid because of epidemics of opioids, which happened in 1985. And this pushing some of the university to search for another and potent and adjuvant for analgesia without narcotics. And the second thing about that, if you know that by statistics, that 3 to 5% of the people going to OR coming out with a drug-seeking behavior or addiction. And I will try to make a spotlight in my lecture about the opioid-free anesthesia and analgesia from bariatric, because it's inspired by bariatric surgery, to a regular practice. And this is my beautiful city in Ras Al Bar in Demirta, which my family lives. And I hope one day to return back again to stay there. And don't have any conflict of interest about my presentation. So my learning objective will be history and the reason behind opioid-free anesthesia and analgesia. I will discuss some issue about sparing technique and the modalities, challenging of opioid-free anesthesia, evidence behind, and the home message for all my colleagues, especially junior staff. So I actually have nothing to say. So my presentation should only last an hour or 2 or 3, but I'm joking. It will take about 35 minutes or 30 minutes. Now don't speak about good or bad. This is not good or bad. It's more better than narcotic, opioid-free anesthesia, or bad. I speak about another concept, another thinking about anesthesia, because nothing is stable. This is a picture of my grandson in Malaysia when he was four months. And this change again, become 2.5 years in Rwanda in Africa. And now he's 5 years in Turkey, and everything changed. And nothing is fixed, and everything liable to debates. And you can see that's 5 megabyte hard disk driver in 56, and now it's 1 terabyte micro SD. So everything changed. What we think is the future, everything will change. And this is a very interesting picture about 1902, when just selling a mummy, it was a very good business at that time, and everything changed, become illegal now. So what we know and what we want to know about anesthesia and analgesia. Now we know a lot about why the pain happen, and how can you prevent the pain, how can you decrease the pain, but still many questions to be answered about pain. Now we know that there is a many pathway, many channels for pain transmission. It is not just a cable, it is a cable gate, and most of the analgesia working on this cable and this gate. So there is a central glutaminergic system, spinal dynorphin, descending facilitation pathway, which is and also descending inhibitory pathway, which is dependent on noradrenaline and serotonin. And if there is a genetic mechanism, and there is a decreased uptake, and there is other mechanisms we don't know about it. So many things can work on different sides of this, from the periphery to CNS to processing for the pain to descending pathway. And narcotics or opioid take a very minimal part of this pathway. But all the time we think it's a major drug because this is a very potent drug. But this potent drug can't work for any types of pain. And there is also behavioral, environmental, physical, cognitive, interventional movement, and many things can, what's called multifactorial, to affect your pain. But what we don't know about pain, why some pain respond to some medication more than others. Like, for example, shooting pain can respond to carbamazepine more than other medication. We don't know. Why some pain respond good for one patient and not for the another? You have the same patient with the same disease, with the same pain, but some patient respond to analgesia and some patient don't respond. And up till now, we don't have a guide for monitoring nociception. Just to have monitoring like an inotropy and other thing for the anesthesia, but we don't have a real management how this nociception happen. How can we monitor that? Also, narcotic-free anesthesia or narcotic-based anesthesia is better. Still, many questions to be answered. We still need more data. And also the question, are opioid mandatory to anesthesia during anesthesia, is still, I think, is an answer it will be no, but we need more data and more research for that. And what is the reason behind opioid? Because sometimes we do something and we think this is the only thing you can do, and just we imitating each other until someone come to debate, because there is a reason behind that. So this is the beginning of the story. The anesthesia starting like this, what's called restraining muscular anesthesia, without any anesthesia. And my grandpa, they have an amputation of his foot without anesthesia. This is in the early 40s of 19th century. I don't imagine how it happened, but this is happened. This is a part of the history. And after that, it come for general anesthesia progressing, and we inspired about regional anesthesia and local anesthesia from dentists. And now just you can use an ultrasound for regional anesthesia. And until the complete setting of anesthesia happened, and there is a complete setting of anesthesia, regional anesthesia, multiple drug use, and there is a monitoring. And not even not even the anesthesia time, because the anesthesia extended to preoperative, intraoperative, postoperative, even recovery of the patient like this. It must be smooth, not like this all the time. So the perioperative optimization is a very integral part of this types of anesthesia. So the scope become extended from surgical time is the very short time of anesthesia time, and also preoperative time is the anesthesia time is a part of this time. So if we return back to the history of narcotics or opioids, it started by Baba Seminiferum, who know all these plants, and this white stuff coming from the plant. Opioid came from this thing, and it used a very long time. 300 BC, opium was used. In 1806, morphine was extracted from this plant. In 1940, mibradine, methadone, naloxone. In 1959, fentanyl came as a synthetic. After that, the concept of stress-free anesthesia was narcotics. From 1982 and 1984, there is a fentanyl. So fentanyl, carfentanil, was not used for clinical purpose, and remifentanil came as a synthetic from the opioid. And all these drugs named that opioid drug. But before that, it came from Evicina, which used this white stuff and dry it and put it in the sponge.
ايوه محمد.
Right? Yeah.
طب ثانية واحدة هقفل بس.
Sorry, can you mute your mic, please? Use this drug until, and the story said that Evicina, he died by overdose from this drug because they don't know the addiction and the dosing of this medication. What about how I thinking usually about the narcotic-free anesthesia? Because there is a scary statistics come from America and from epidemic crisis started in 1985. They find usually American look for the economy, even the researchers push the economy. 55 billion in health and social costs of opioid used, and 20 billion in hospital care for opioid positioning. 2.4 million have severe opioid disorder. And now, in most of the schools in America, they have naloxone because it become a public problem about the opioid. And you can ask me, what is the relation of addiction and the narcotic-free anesthesia? I can tell you that about 5% of all people going to the OR came out drug-seeking behavior. And I have many patients. And if you work in pain clinic or just addiction clinic, you can find many stories. I have a story of patient just come for carpal tunnel syndrome. Now it's drug-seeking behavior. Started from carpal tunnel syndrome as analgesia. And you can know from the epidemiology that 650,000 opioid prescription every day in America. 3,900 initiated non-clinical prescription. And 78% died every day from the use of narcotics. And in America also, American prescription is about 80%, and the number of people is all over the world is 5%, so very high and very problematic thing. But don't think that you are away from that. We are engaged in that, but the problem, we don't have a real statistic about that. And this graph, you can see increasing use of narcotic, and unfortunately in America and in our country it may be more than 75% from this narcotic started in the hospitals. So the problem was pain, starting opioid and prolonged recovery, and opioid side effect, inadequate treatment of pain. You increase the dose until they make a patient drug dependent and chronic pain all the time. So can we use an anesthesia without opioid? This is a very difficult question, because this is a triad of anesthesia, what we learned from the beginning of our story. But yes, we can, because this has happened. You know that in 1990, you know, some university like Mayo University or just another hospital just searching to how to decrease this crisis and change the narcotic as the basic use medication in analgesia for OR to be an what's called supplementary and not needed. And this is because we have many options now. It was difficult in the starting of the story of anesthesia, but now we have many options. You have many options to use and to replace the narcotics, opioid, and at the same time get the same effect or more better effect. So opioid-free anesthesia, you need a hypnosis, some paralysis, amnesia, hemodynamic stability, immobility, neuromuscular blockade. We can do that without narcotics. I got this paper from Dr. Yasser Reda, and you know that opioid indispensable general anesthesia. They said that opioid is still very useful, but more using opioid, and the advice to using opioid more conservatively because of this crisis. And the second thing about more use of narcotics, opioids, the more you get post-operative pain, and the more you got hyperalgesia, and this is related to the dose and the time. And so a patient were treated with high intraoperative doses of opioid had a higher post-operative pain intensity. Against what we know, against what we believe in analgesia. And you must balance it between your dose and dependent and the drug-seeking effect or addiction effect, and also the analgesia. So in my lecture, I just try to showing the concept of paradigm change about not to use narcotics. And you can tell me it's very difficult, but at least I tell you to decrease as the lowest as you can possible from the narcotics. And now, we are pushed to do that because we have many options. As I told you, we have many medication, we have regional anesthesia, we have many things to do. So what is narcotic-free anesthesia? Part of multimodal anesthesia, and many drugs that can be used. And the multimodal anesthesia, narcotics is one of the drugs to be used. What is the best strategy to avoid opioid anesthesia and analgesia? Not to do operation. And this is a silly question because we must do some operation, and we need at that time analgesia as a part. So, and this is multimodal practice, but all the time multimodal practice, post-operative and narcotics, it will be a minimal part of that. And even of multimodal analgesia, narcotics is one cubic only of this analgesia. And why this is appear to the surface for non-opioid analgesia? Because there is a interesting paper about incidence of iatrogenic opioid dependence or abuse in patients with pain were exposed to opioid analgesia therapy, a systemic review and meta-analysis, and they said that 4.7% of those people came to the OR coming out what's called addict. And addiction is not only for narcotics, many drugs, no drug is safe. And this is a picture, one of the addicts sent me this picture, and he feel his life like this. And usually addiction go sending to the grave or to the jail or to kill yourself or to kill one of your beloved. So in 2017, the annual meeting of October, they said about elimination, ASA, elimination of opioid from anesthesia, decrease post-surgery nausea. It is looking for one aspect. Again, in a study in 2008 of about 13,000 surgical patients, and there is a correlation between opioid use and mortality and morbidity. And this picture from Egypt, this patient about 500 kilogram. And you know that if you have a patient like this, you think seriously to give him narcotics. This patient is anaesthetic by narcotic-free anesthesia. And the inspiration of the idea came from Australia. And then, as I told you, in 2019, there is a program, official training program from my clinic for narcotic-free anesthesia, started very early, about 30 years ago. And even they make an announcement about opioid-free anesthesia, future of pain management. And in as elimination of opioid from anesthesia, decrease post-surgery nausea, and this is one aspect, and decrease many problems for narcotic use anesthesia. And for University of New England, making systemic analysis of opioid-free general anesthesia versus opioid-based general anesthesia, and the conclusion that opioid-free anesthesia are more better, and recovery more better, and addiction less, and many things. And also the Cleveland Clinic is changing its approach from opioid-free strategy, from opioid-dependent strategy to opioid-free strategy or alternative pain management and new prescription guideline. So the goal for avoiding opioid in obese and in other patients, because they have many side effects, and some of the devastating side effects is the tolerance and addiction. But there is many other side effects like urinary retention, tolerance, dizziness, opioid-induced hyperalgesia. And instead of reducing analgesia, we reduce hyperalgesia. Worse outcome in oncology, but this is an only animal study, it may be practicing on human or not. Remifentanil, this is a study to show that remifentanil, according to the dose and the time, increasing the hyperalgesia. And all people just working with remifentanil can see that hyperalgesia to get pain instead of analgesia. So what is opioid-free anesthesia? Avoiding opioid in preoperative period. This can be practicing, maybe. Bariatric anesthesia encountered paradigm shift in this scope, because we push to do that in bariatric patient, because we can't use a big amount of analgesia, but it may be practicing in many practices. Also, this to decrease the limiting the opioid side effect. And we inspired by bariatric surgery, and many publications came from all over the world. So even Bayer, he said, conclude, giving the decline rate of mortality and morbidity following common elective procedure, no persistent opioid use represent an important common and recognized complication of preoperative care, and it's very important. Goal of avoiding opioid also in obese and other not obese, respiratory depression, central muscle rigidity, pharyngeal muscle weakness, obstructive breathing, especially in obese people, negative enotropy, nausea, vomiting, ileus, and constipation. And because of that, Miller group from Australia even put in guidelines or just a method how to make anesthesia, and all the time looking for to get a stable anesthesia, stable post-operative, more better outcome. And this is a picture, I got it from Australia also during a narcotic-free anesthesia. And you can find all the things on the monitor is good, and no hemodynamic instability, heart rate is okay, symbolosis, and the amnesia is the same, is very good. And this came from Sydney University. So indication of opioid-free anesthesia is started by obese with obstructive sleep apnea. Pulmonary disease like asthma, COPD, and other cystic disease. Acute and chronic opioid addiction is very important. Previous hyperalgesia problem happened with individual surgery. Complex regional pain syndrome, or just chronic fatigue syndrome, or fibromyalgia, what's called chronic unspecific pain syndrome, oncology surgery, and inflammatory disease. And opioid-free anesthesia, it can be used in obesity, opioid addiction, chronic pain syndrome, colorectal cancer surgery, and obstructive sleep apnea. And also it is a major part of fast tracking in anesthesia. And this paper came in Anesthesia and Analgesia, opioid-free anesthesia in the era of enhanced recovery after surgery under the surgical home. Implication and post-operative outcome and population. They said that the aim of anesthesia and analgesia is no harm, as Hippocrates said, and the great harm happening with opioid-based anesthesia is just asking us to advising us to push away from this technique. And it is a major part of all the fast-tracking anesthesia. Don't avoid what's called an long-acting narcotic. Now avoid narcotic at all. And what is the current barrier? Why all not people just can use this method as a good method just for anesthesia and analgesia? Because it's a cost. The cost of other drug is maybe more than the cost of the narcotics. Also, they need more research and more practice guideline. And the problem of lack of training, because of that, Mayo Clinic make just a training program in 1990. And we need also still insufficient guidelines and limited data about the different surgery. But most of us just found the easiest way to make the patient silent, to get the gift, but you are all the time playing with the shark, so to care. And also, I'm telling you that opioid-free anesthesia is not one fit all. It can't be practicing on all anesthesia until we have a fixed guidelines and more data about it. So what is the pitfall about opioid-free anesthesia? If you have an excessive sample sources from other drug, sometimes you use an ephedrine. It can be solved, this pitfall. Inadequate symbiosis, I can use drug like clonidine or dexamethasone. What's called theoretical risk if inadequate analgesia, and which may be required an opioid, but sometimes it's a theoretical risk because all the study not showing that. Post-operative excessive sedation of dexamethasone, I can just adjust the dose for that. So they have many benefits of opioid-free anesthesia. Like it is an immunomodulatory function, multimodal disciplinary pain technique, and less side effect, and leaves the immune receptor to be naive because the more you give the narcotic, the more you need a narcotic, and less born to overuse, prescription misuse, abuse, and the addiction, prevention, prevent sensitization, hyperalgesia, and tolerance. Also, prevent what's called providing the post-surgical pain syndrome, early dependent of intended oncological treatment, and this is what's called a debatable area. Early return to, early hospital discharge lead to improvement of the cost of the control. This is the debate again is this is a costly or not costly. Mitigate opioid-related adverse effect, and the most important thing, this prevention of opioid crisis, and also promoting the other technique to be invalid on to come to the floating to the surface, like regional anesthesia, ultrasound-guided regional anesthesia. What is the contraindication to this technique? Allergy to one of this drug. If you have allergy, you can't do it. Heart block and pre-existing bradycardia, or hemodynamic instability like shock state, because you need that what's called limited control of that, and you don't have experience to do that. And stable ischemic heart disease, autonomic neuropathy syndrome, sometimes you can't control the hemodynamic of the patient. What is the evidence about that? But before to tell you our evidence, I must tell you that absence of evidence is not evidence of absence, because sometimes there is no evidence because there is no study, or the study it will be unethical. So just study came from Saudi Arabia, non-opioid versus opioid-based general anesthesia technique for bariatric surgery, and they found that the opioid-free anesthesia are more better, and outcome more better, the recovery charges are more better. And again, from Korea, opioid-free anesthesia using continuous dexamethasone and lidocaine infusion for spinal surgery, and avoiding opioid is one of the target of their study, and this is proven that opioid-free anesthesia more better. Here from Egypt in Lab Coli, and see that more better outcome, less post-operative vomiting, more control of pain, and less crisis, narcotic crisis, and more better. So again, many studies showing that opioid-free anesthesia is more better. This is an analgesic impact of intraoperative opioid versus opioid-free anesthesia. Systemic review of meta-analysis. Again, they say that the evidence of opioid used in anesthesia don't have a higher evidence that it will control the pain, or just give it more pain control, but the outcome more better without use of narcotics. And again, this is another paper. Also, this more paper. This is efficiency, evaluation of efficiency for opioid anesthesia for laparoscopic cholecystectomy, and opioid-free anesthesia exhibits a lower incidence of hypotension, lower rate of nausea and vomiting, a lower demand of analgesia in the early postoperative period compared to those receiving opioid. There is a very interesting subject, many subjects every day. I got it for even today. I get a very interesting paper about regional anesthesia and avoiding opioid. And this is one electrospinal brain block in cardiothoracic surgery. And this is, I bring it, this just published it February 2021 about ultrasound-guided quadricelamboram for postoperative analgesia, systemic review just to avoid narcotics. This is a conclusion. They have a very good rule, decrease narcotic use for anesthesia. So now starting the debate, I think the debate starting about 30 years ago, but now because we have a bariatric surgery and increasing number, the debate started opioid-free anesthesia or opioid-based anesthesia. But to know that Euro Anesthesia 2016 to make a last first debate about opioid-free anesthesia. Now many conference for enhancing recovery about opioid-free anesthesia, many conference, and even the organization, what's called SOFA, Society of Opioid-Free Anesthesia. And this is a website, this is a page of website of the society. And I ask you a question about, that about beautiful anesthesia, idealism and duality. You can tell me that I can avoid completely now the opioid, but I can tell you, you can decrease as possible as you can and to bring the most outcome. And you do that because when you started our career, I think the old people here can understand me more better, that we don't use except narcotics because we don't have except narcotics. Now we have many drugs IV, like nonsteroidal anti-inflammatory. We have alpha-2 agonists. We have many drugs that can work in anesthesia. So there is a difference between idealism, not to use the narcotic-free anesthesia, and reality, we can decreasing as possible as we can use for anesthesia and analgesia. But we need more research, and this lecture is not an time for research because time is squeezing all the time. And my conclusion, opioid-free anesthesia is alternative standard for opioid-based anesthesia. You must thinking a lot about it as a concept. Multimodal anesthesia, just as magnesium, ketamine, alpha-2 agonists, and systemic lidocaine are effective in avoiding large doses of opioid. Hypnosis, analgesia, amnesia, and sympathetic blockade and hemodynamic stability can be achieved with this technique. And now we are in the era of multiple choice. We have many choices of analgesia, not like before. So no medication is benign, you must know that, and pain management is multifactorial, clinically challenged. The opioid epidemic pushing the people to take a decision, sometimes hard decision, about to decrease the opioid. Understanding of both opioid and opioid-free technique may help to reduce epidemic. Similar analgesic adjuvant agent can be used postoperatively to maintain opioid-free anesthesia. And this is practicing, but we are on the first step to do that. A study from independent unit worldwide as awaited. We wait more study to get an cemented evidence about the opioid-free anesthesia or opioid-free anesthesia. Sorry, I make you too confused, which is more better now, but I don't know. I don't have the answer for this question. At the end, opioid-free anesthesia is possible and is alternative for opioid anesthesia. It's better for selective growth patient, not for air patient, as I told you, not one fit all. Might be better for most patients, maybe in the future, as the future of anesthesia is paradigm shift. I don't like to be like this penguin, to push someone to use this technique and they don't have any experience and they just fall in trap, but just you must have a training to use opioid-free anesthesia, to have some training, some knowledge about it. And we need more research as usual to become an evidence base. And we don't know what's happening in the future, we don't know. Don't come in. It may be, for example, seeking to be instead of your feet to be in your tummy like this. We don't know, but we are inspired that there is a new medication come in the future, like liposomal bupivacaine and many other medication on the horizon. We don't know. It may be replace narcotic completely. And I hope, inshallah, next year to be overcome this coronavirus. But you must know that a doctor is a student till his death, and when he failed to be a student, he died. Said that William Osler is a big writer and physician from Canada. Thank you very much for your attending my lecture and question and answer. Thank you.
Thank you, Dr. Yasser, for that wonderful session. The floor is now open for questions. If anyone has any questions, please type it down in the Q&A tab that you'll find at the bottom of your screen. Dr. Yasser, we already have about 3 questions now. The first question is from Dr. Fatma Gohar, who asks, what is the dose of opioid that can cause addiction post-operatively?
You know that we don't have a fixed dose, but the more you use and the time for using is reflected to the addiction. You know, and the problem, unfortunately, the problem is not related for the extension of the operation. So, for example, if you got a very big operation like cancer operation and stay in ICU for many days and you get a very big amount of narcotics, there is no clue this patient will get an addict. As I told you, I have many patients started by carpal tunnel syndrome, even fracture little finger, and become an addict because there is many factors like genetic factor, social factor, just for addiction. And up till now, we don't have a clue data about that. We don't have a data about that. This is a research is running. There is no fixed dose. But my advice, the lowest dose you use, the maximum protection for your patient.
Thank you, Dr. Yasser. The second question is from Dr. Saukanya Iskandar, who asks, What about opioid-free anesthesia in cardiac surgeries? I think you already dealt with this, but the question came before that slide. But if you have a few words.
There is just sorry, because I have thousands of research about a specific area or specific surgery, like laparoscopy, like open surgery, like heart surgery. In heart surgery, there is many study about that. You can send me for private. I can send you many study about that. For example, electrospinal plane block as use or paravertebral block, or even thoracic transverse block for surgery, and give other drug medication and very little amount of narcotic, not like before. When you get an 50 microgram fentanyl per kg, now become 10, become 5, become nothing. And this is in some cases, and in some study, and even in some randomized control study, give a very good result and comparable to narcotic-free anesthesia. And if you need the paper, I have many paper for that. I can send you personally.
All right. Thank you. So the next question is there any evidence of OFA with regional techniques decrease cancer recurrence in oncological surgeries?
Yeah, there is many study, but most of the study is animal study or a special type of cancer. So we don't have a solid data, but you know that when you read about this, you found that most of the time said to you that the more use is even for surgery, for hepatic surgery, more use for narcotics, the more use of the more recurrence will appear for the patient. But most of the time, this is an animal study. It may be and disease specific. I can't see practicing for all surgery. We need more data to see that the use of narcotics can be some immunomodulation which decrease or increases the recurrence of surgery. But we have some solid data from animal study, and we don't have a solid data for all the diseases. It may be for liver, it may be for other diseases.
Abdurrahman.
Sorry, I'm sorry for the interruption. Yeah, I think there was sorry for the interruption. Please carry on, Dr. Yasser. Yeah.
It's okay. Yeah, Dr. Laffer, I listen.
Yeah. Okay. So the next question for you is, what drugs can be used in opioid-free anesthesia?
Many drugs can be used, from lidocaine infusion, magnesium sulfate as analgesia, dexmedetomidine as alpha-2 agonist, ketamine can be used, non-steroidal anti-inflammatory, even paracetamol. Many drugs can be used. And there is also a regional anesthesia is a major integral part of this blocks. And I found a study done in Saudi Arabia, they make an anterior fixation for cervical spine by paravertebral block only. You know, they don't give any anesthesia, and the patient was awake. So as a regional anesthesia as a major part, and this is pushing the study and ultrasound-guided many blocks. You know, every day I found a new block with a new name, and you have a problem now with the name. What's the name of this block? But regional anesthesia, alpha-2 agonist, ketamine, lidocaine infusion, magnesium sulfate, many drugs can be used.
Yes.
Sorry, Lever, because all of us, especially young generation, he do that. He do what's called narcotics, decrease the anesthesia or free anesthesia, but not just totally free, because he have many options now. We don't have this option when we started our career about 32 years before. You know, we don't have all these options. So it was totally dependent on narcotic. Now is shifted the paradigm. But you know that one day, I don't know, one day it will be narcotics free or not. I don't know.
Sure. I hope that day comes. So next question is from Dr. Mohammed Suleiman, who asks about cannabinoids and how is that legal for the public? What is our role as experts to illuminate the risk?
You know that I'm telling you that 75%, and I think more that in our country, because all people don't depend on the hospital and don't depend on black market outside. So I think narcotic-free anesthesia or decreasing a number of dose of narcotics can help us. I have many patients in my clinic. And one of him, I tell him, you are dependent on the drug. You must try to remove this drug from your blood. He cried to me and they tell me, I don't know anything about this drug. Your colleague starting this drug with me and become addicted because of that. What I'm telling you now is that 75 or 80% of addiction come from the hospital. So you must care about your patient. And you can see in pain clinic, I found severe pain clinic, neuropathic pain. Someone, he don't know anything about the pain, he give him narcotics. And the patient become dependent and the patient not resolved and he need more dose all the time. So if we decrease the narcotics all the time for our patient and with multimodal fast tracking technique, it will help the patient all the time. And I use that in my practice. You know that I'm head of regional anesthesia and pain management. Most of the patients come out with regional anesthesia with a very little amount of narcotic, and some patients don't take narcotic at all. And the outcome is very good, but you know, this is a belief. It needs a time to change.
Sure. The next question, Dr. Yasser, is what about fentanyl patch for post-operative pain?
This is, I think, Dr. Mohammed Makhalita was us here. This is, you can't control a patient with acute pain with a narcotic like this, because you can't judge the pain. The pain is severe or not severe. And this is take a very long time to make a plasma level, you know, and this is a bad practice. You know, this is not an evidence or not evidence. You can find some people in that, but it's all the people is weak, all the people pushing away and a very bad thing, you know. So don't use an fentanyl patch for post-operative pain. It can be used cancer pain, it can be used for other pain, but this is a very bad choice. Don't use it. And I think Dr. Makhalita have a long debate about that. You know, it's more better.
Looking forward to listen to his lecture. So as we're running out of time, I think we'll take last two questions.
Yes.
The next question is, why not apply the DSM-5 criteria for opioid use disorder as a method?
What is that?
This is Dr. Ahmed Katab. So he is asking, can we use the DSM-5 criteria for opioid use disorder?
I don't know this DSM-5. What do you mean by DSM-5?
Dr. Ahmed Katab, if you would like to explain or expand on that.
Yeah.
By typing another question.
Yes, give me another question until you're right.
Okay, but until we get back to that. So the next question is, what about the stress response of intubation?
This is the stress response. It can decrease also by this medication. You know, if you got an esmolol, for example, if you give an alpha-2 agonist, this or xylocaine, or just to make the patient in a deep level of anesthesia, don't have this stress. You know, narcotics is not the only drug with preventing the stress of anesthesia or the stress of intubation or any stress. There is other drug can do that.
Very true. Well, what would you recommend? Maybe that's what he's asking.
You can use an esmolol, you can use an xylocaine before intubation. You can just let the patient to get a deep level of anesthesia, and it works. All this is work.
All right. So the last question before we wrap up your session, Dr. Yasser, is what is your experience with magnesium dosage and administration?
You come into my area because my MD and about 20 years it was an early thing about magnesium sulfate infusion in the preoperative period. And I use this magnesium sulfate in a dose about 20 milligram per kg as a bolus dose, and 20 milligram every hour in an open abdominal surgery. And this was an early study 20 years ago, but now as magnesium as a NMDA receptor antagonist is a very good drug, but you have some drawbacks like some hypotension that happen, potential action of muscle relaxant. But as a drug, it can be used for analgesia, and it's very effective, good drug. And most in my study and many study after that or before that, it decreased the narcotic requirement. It decreased morphine BCA in my study about 60% with the same optimal analgesia. So it's a very drug, but you need an adjuvant drug with it. It's not the only, you can't use one drug to compete him with morphine. The morphine is the father of opioid. And morphine, the name came from Morpheus, the god of dreams. So you can't compare one drug, but the mini drug can make the same function in a better way.
Right. Thank you, Dr. Yasser. You have many more questions, but unfortunately, I think we've come to the end of
you can send my email, or just send it for the site. I can just answer this question. I will write my